So good morning. My name's Casey Adams, and I'd like to talk to you about my transformational project, implementation of multidisciplinary rounding. I would like to thank Dr. Dupre for her support. It's been a challenging semester, and I really appreciate everything that she's done for me. And then also Elizabeth Larkins, who is my community member. However, she's not able to be with us today because at this very moment, she's defending her doctorate. So she can't be with us. Multidisciplinary rounding, or MDR, is the process of having two or more disciplines, usually RNs, providers, case management, and ancillary departments such as physical therapy or occupational therapy, meeting to review the plan of care for a patient, improving the communication between various team members to keep everyone working towards the same goal, which is the ultimate discharge of a patient. This decreases the geometric length of stay, which is how the hospital where this translational project will be conducted measures a length of stay. So what is geometric length of stay, or GMLOS? So this GMLOS is based on a diagnosis related group, or a DRG, which is a system of grouping together similar patients, and then specific GMLOSs are assigned to each DRG. So having an increased GMLOS leads to extended ED patient boarding hours, an increased risk of adverse patient events, and decreased staff satisfaction. The background and significance of this project, currently on the medical unit, S4D, where this project will be implemented, the GMLOS has increased to 5.62 days for FY 2021, which is 1.12 days above expected. The purpose of this project is to implement multidisciplinary rounding, improving communication between the disciplines to impact geometric length of stay, ED border hours, and adverse patient events. So in addition to having the increased GMLOS, the unit currently does not have a process for multidisciplinary rounding on the medical unit, which has led to that lack of communication. The unit has experienced an increase of adverse patient events. There's been an increase of ED patient border hours, and then also there's a concern regarding the impact on staff satisfaction. The PICO question for my translational project is, among providers and nurses caring for patients on an acute care medical surgical inpatient unit, how does implementing an evidence-based multidisciplinary rounding program compared to current practice impact the GMLOS, adverse patient events, and ED border hours over 6 months? Key search terms utilized for this include decreasing length of stay, interdisciplinary rounds and length of stay, or hospitalization or length in hospital, multidisciplinary rounding and decreased length of stay, increased length of stay and decreased staff satisfaction, and interdisciplinary rounds and ED boarding. Databases searched were PubMed, CINAHL, and Ovid. The Prisma model narrowed down my literature review to 5 driving articles. There were specific inclusion and exclusion criteria for the literature. To be included, an article needed to be specific to medical surgical units, could use the term interdisciplinary rounds, which is used interchangeably with MDR. Length of stay, the hospital and unit where the literature's data was gathered could be of any size. Exclusion criteria included anything that was specific to an ICU, pediatrics, and cardiac units, as those tend to be much more involved than on a general med surg unit. The articles also had to be published in English and could not be older than 2009. I would like to highlight some of the key points from the 5 driving articles. Bumpus and Copeland, they improved, or they showed that multidisciplinary rounding improved communication between staff and patients. The implementation of an MDR had an increase of 4.23% in patient perceptions of understanding of their care. Providers had a positive response to the MDR as well. It's important to note that being timely and concise increased compliance and satisfaction of the staff. The second article is Cornell et al., and they implemented MDR on 3 medical surgical units. They also identified that having a mobile MDR on a med-surg unit can lead to distractions, slowing the process, which is important for my project since due to COVID, the MDR will be being completed virtually. HCAPS did show an improvement in communication with nurses, which does lead to job satisfaction. The third article is written by Dunn et al. Implementation was completed on 2 medical surgical units and did utilize initially a mobile MDR. Shared outcomes related to a decrease in length of stay, staff and patient satisfaction, and looked at clinical deteriorations. The length of stay was decreased for patients that transferred into the unit, not necessarily those that were directly admitted to the units. They couldn't explain why, but that was an interesting fact. And then patient and staff satisfaction did increase. They found that the mobile rounds versus meeting in a conference room did not have any impact on the length of stay, satisfaction, or in-patient deterioration. Gary and et al., they completed multidisciplinary rounding on med-surg and telemetry units. They did show that they successfully decreased the length of stay and increased communication between the various disciplines. And through that, they increased throughput from the ICUs to the acute care units. Staff had an increase in satisfaction, and it was due to they reported being more aware of a patient plan, and ancillary referrals were not being delayed. Staff felt much more comfortable having the MDR away from the bedside. And finally, Mercedes et al., they implemented a structured MDR to positively impact the length of stay, satisfaction of staff through improved communication and collaboration. They conducted multiple studies, and they did show a trend in decreasing the length of stay. And 6 of the studies showed an improvement of staff satisfaction post-implementation of an MDR. After reviewing the literature, the following gaps were identified in the research. A lack of MDR specific to medical surgical units in acute care settings. The majority are conducted in ICU or cardiac units. The number of safety events were not quantified during the pilots. And the use of the overall length of stay versus the geometric length of stay. Again, the hospital that this will be conducted at utilizes the geometric length of stay. And so most everyone else just use the average length of stay. The literature also highlighted gaps in the implementation unit's current practice. Currently, there is a lack of MDR to facilitate discharges and prevent extended length of stay. There is a lack of communication between the disciplines. And there is a lack of understanding of how ED border hours is impacted by inpatient units. This is a quality improvement project that includes both quantitative and quality measures with pre and post assessments. The quantitative measures that will be looked at both pre and post implementation include the GMLOS, ED border hours, and adverse patient safety events. Qualitative measure will be the data collected from the focus groups assessing employee satisfaction, both pre and post implementation. The logic model displays the resources, evidence-based interventions, proposed outputs, and the anticipated outcomes, both short and long term, and the overall impact. The anticipated short-term outcomes include having a 50% of the barriers to MDR identified and resolved within 3 months, and having 50% compliance with MDR in the same time frame. Long-term outcomes anticipated are that there will be an 85% compliance in MDR and that there will be at least half a day decrease in the GMLOS. The anticipated outcomes of the project is that there would be a decrease in the overall GMLOS for patients and that there would be an increase in staff satisfaction and retention. To implement this plan, I will utilize the following steps. Step 1 would be gathering baseline data and then implementing a pre-implementation survey for perceived barriers and satisfaction. The second step is to establish the focus groups to discuss potential barriers and solutions. The third step would be education. So that would be provided to everyone involved in the MDR, and we would also provide just in time education before the actual go live date. The fourth step is true implementation of the multidisciplinary rounding, which is anticipated in January 2022. And then the step 5 is the post-survey and post-implementation data. And then we would hold a final focus group to just review the data that was collected. The translational project will be implemented at Northeast Georgia Medical Center located in Gainesville, Georgia. The Gainesville campus is one of 4 hospitals in the Northeast Georgia health system. NGMC is a 557-bed level 2 trauma hospital that services 13 counties. The implementation unit is a 25-bed medical unit that sees a variety of patients, including oncology. This hospital and unit were chosen because there is an engaged community member who serves as the executive director of nursing at the Gainesville campus. Implementation is being conducted on a unit where improvement is strived for. NGHS is a teaching hospital where providers, residents, and ancillary staff work well together and are open to improving patient and staff satisfaction. NGHS also has an excellent IT department to assist with reports in the electronic health record, which is Epic. Finally, the overarching theme at this facility is the hospital mission statement, which is committed to improving the health of our community in all that we do, which includes being open and supportive of quality improvement projects to improve patient care. Anticipated barriers and possible solutions have been identified. Anticipated barriers include staffing burnout and resistance to change and turnover. Discharge facilities are full or are limiting admissions when the COVID census is high. Due to restrictions of gathering placed on us by COVID, MDR would need to take place virtually. And currently, the unit does not have a case manager. It is being filled with a traveler case manager. Solutions for these barriers include improving the vacancy rate, recruitment, and retention. Facilities are now admitting COVID-19 positive patients. Virtual MDR can be implemented utilizing Epic, and recruitment efforts for a permanent case manager is currently underway. During the SWOT analysis, I found the following internal strengths and weaknesses. Strengths include the hospital leadership support, electronic health record reports. This is a teaching hospital which hosts an educational environment. Some of the internal weaknesses include the lack of the MDR, an increased GMLOS, lack of employee engagement, and an increase in patient adverse events. External opportunities identified were that a less acute patient could be transferred to one of the sister facilities, opportunities for recruitment of additional staff, and improving the hospital reputation. External threats identified included a decreased workforce, strong competition in the area for both our patients and our staff, the risk of losing accreditation status due to increased adverse events, and decreased reimbursement since CMS only reimburses for GMLOS. So expected outcomes and impacts are attain goal for GMLOS, decrease ED border hours, decrease inpatient adverse events, and have a positive impact employee satisfaction and work environment. In order to stay on track, the following timeline was developed, which shows our current state, the qualifying exam, and then seeking IRB approval. In the first quarter of 2022, implementation of MDR is expected with identification and removal of unforeseen barriers. Data collection will begin and metrics will be tracked. The second and third quarter of 2022 is continuing to collect data with completion of data collection for this project at the end of the third quarter. The final quarter of 2022 would be pulling all this information together with preparation to present results in November. At the conclusion of the project, I will present to NGHS's shared governance, which is VOICE. The theoretical framework that I chose to guide this project is Imogen King's theory of goal attainment. This theory was chosen because it focuses on the interaction of nurses and patients in reaching goal attainment, which is discharge for the patient, which is the overall goal for this translational project. Ms. King's theory also utilizes the importance of incorporation of the environment and has been shown to be successful in the use of developing a successful MDR due to the collaboration of the healthcare team and patient. Couple of good quotes that I saw here. Goal attainment theory is based on her conceptual framework that focuses on that nursing and interaction with clients to develop and reach goals. And decision making is a shared collaborative process where the nurse and client share information for the purpose of setting and attaining goals. The diagram that you see here is a visual representation of Ms. King's theory of goal attainment. From the diagram that you can see that the nurse and patient each have their own perception, judgment, action, and feedback regarding an interaction. The reaction is the meeting and discussion, interaction is setting goals, and the transaction, if successfully, is achievement of the goal, which in this case is discharge. On the right side of the diagram is the dynamic conceptual system that Imogen King formed the goal attainment theory from. And in the center, you'll see the individual, which is our patient. The individual interacts with the group or interpersonal systems. This is the MDR process where there is cooperation with goals and the nurse-patient relationship is formed. And then the society, which is the outermost one, equals the social systems. And this is where there's an impact on the goals of this translational project, as well as the goals of the organization by decreasing border hours, GMLOS, and improving employee satisfaction. The leadership theory chosen for this project is transformational leadership. This theory was chosen because it values transparency, inspires change, promotes teamwork, motivates employees to be higher functioning, and empowers the team to be involved with developing and implementing policy, which is the outcome of the MDR. As part of transformation theory, I wanted to highlight the cooperation theory. With this theory, the leader engages in the same activities as the staff, which strengthens work relationships, improves morale, improves productivity, and has an impact on satisfaction. Once the translational project has been conducted, there are methods that have been discussed to continue the process implemented. These include continuing to follow metrics of daily participation in rounding and tracking monthly GMLOS data to monitor trends. Employee satisfaction and retention will continue to be measured quarterly, and all new staff and providers will receive MDR education at onboarding and annually. This is the list of references utilized in the project or in this PowerPoint. And then I'm open for any questions.
Thank you, Casey, for starting off our junior session. I'll open it up to your committee now.
Hi, Casey. Good job on your presentation. I know you put a lot of work into it and it showed, so good job on that. I know we talked a lot about anticipated barriers to the MDR and the fact that you're going to conduct them virtually. And I know that you had collaboration with the former student. You want to tell us a little bit about that?
Yes, Dr. Charles Hammer, he was gracious enough and he spent about 2 hours with me one night virtually discussing a project that he did. I believe it was at Erlanger there in Tennessee, and how he was able to positively impact. He was looking more through ED, moving ED borders out. And it was really impactful that he spoke to having a discharge lounge, which is utilized at NGHS, but that how he took that over and getting patients off of the med surg unit and how he did that, and it helped speed up the process. He provided a lot of really good insights to that I've spoke with my community member about, that it's just things that we didn't think of. And so he was very beneficial to helping me think through this process.
Yeah, and I think the other side of that, it was Dr. Hammer was very happy to help because it was furthering his work and his research to, in part, you'll be replicating some of his work. Of course, yours is a little different focus, but at a completely different organization and a different state. And, I think it's that networking, I think, was very exciting for me to see from one student that's graduated to a current student. So looking forward to the implementation for sure.
Great job, Casey. I just was gonna add, I'm glad that Dr. Dupre helped connect you with Charles, because I wrote down on my sheet over here, I couldn't remember his first name, but I went back and found it while you were talking, because your project sounds so similar to his, and his was such an incredible outcome. And he really did a huge thing for his facility. So I'm glad that you all have already connected. I think he'll be a great resource.
Thank you.
Do we have other questions or feedback for Casey? Thank you, Casey. If you wouldn't mind to stop your screen share.